In this video, we will conclude folate deficiency. Relative folate deficiency in hemolytic anemias is a conceptually distinct mechanism. In hemolytic anemias, red blood cells are being destroyed at an accelerated rate due to various causes. The bone marrow responds by dramatically ramping up red cell production, compensatory accelerated erythropoiesis. This massively increased production rate consumes folate at a much higher rate than normal. Even when dietary folate intake would be perfectly adequate under normal circumstances, the extraordinary demands of the hyperactive marrow can outpace that supply, creating a relative deficiency where the problem is excessive consumption rather than inadequate intake. Finally, intestinal malabsorption affecting folate specifically is caused by two notable conditions. Sprue, also known as celiac disease, is an immune-mediated condition triggered by gluten ingestion that damages the small intestinal mucosal lining, particularly the proximal small bowel where folate absorption predominantly occurs. With the mucosal surface damaged, folate absorption is severely impaired regardless of dietary adequacy. Giardia lamblia infection, caused by a parasitic protozoan acquired through contaminated water or food, also produces intestinal malabsorption and can impair folate uptake from the gut. In summary, folate deficiency is a condition marked by inadequate folate, vitamin B9 levels in body tissues, manifesting as megaloblastic anemia, neurologic symptoms, or increased risk for congenital anomalies such as neural tube defects, especially in pregnancy. Folate deficiency is now rare in populations with mandatory grain fortification, but remains prevalent in groups with poor diet, malabsorption, alcoholism, high physiological demand, certain medications, or genetic disorders affecting folate metabolism. Folic acid supplementation, usually 1 to 5 milligrams orally daily, adults, with lower maintenance doses after repletion, specific regimens for infants, children, and pregnant lactating women. Initiate vitamin B12 first if co-deficiency suspected. Megaloblastic anemia with macrocytosis, oral ulcers, glossitis, diarrhea, neuropsychiatric disturbances, depression, cognitive impairment, and in infants, developmental delay and seizures. In pregnancy, deficiency may be asymptomatic in the mother, but increases risk of neural tube defects in offspring. Common causes include dietary insufficiency, chronic alcoholism, pregnancy lactation, malabsorption, celiac disease, tropical sprue, chronic hemolytic states, certain drugs, methotrexate, phenytoin, sulfasalazine, and inherited defects, e.g. MTHFR deficiency, hereditary folate malabsorption. Untreated can cause severe anemia, irreversible neurologic damage, especially in infants, congenital malformations, and rarely heart failure. Prompt supplementation rapidly reverses hematologic findings and can prevent congenital defects if started preconceptionally.